Okay, I think we'll get started. Thank you, everyone, for coming. We appreciate your time. So I have the honor and pleasure of introducing our AWAEM-GEMA Global Emergency Medicine Travel Awardees for this year. We have a Dr. Olita Shilpakar from Nepal and Dr. Salote Behr from Fiji, and you're going to hear from both of them about their experiences developing emergency medicine in their countries. My name is Mindi Guptill. I'm the chair of the Global Health Committee for AWAEM, and so it's been my pleasure to interact with these women and help them get selected in a very competitive year, actually. We had 50 applicants. So first, to tell you a little bit about Dr. Olita. She is a professor and attending emergency physician in the Department of Emergency Medicine at Tribhuvan University Teaching Hospital in Kathmandu, Nepal. She's one of the first female emergency physicians in the history of Nepal to be trained in emergency medicine, thus serving as a pioneer and role model for other women. She serves nationally on the executive board of the Nepalese Society of Emergency Physicians. She works with the WHO Nepal office, the Department of Health Services and Ministry of Health and Population in Nepal on numerous projects, including developing treatment protocols with the development of the first ever national document on standard treatment protocols for emergency health services. She is involved in high quality research, regular teaching classes, bedside teaching, journal presentations, CME education. She's directly involved with starting the country's first emergency medicine residency and is currently working on that curriculum. Dr. Olita, thank you for your amazing work to improve emergency care in Nepal.
So thank you so much, Dr. Mindi. Hello, everybody. Good morning, and a warm namaste to everybody. I'm Dr. Olita Shilpakar from Kathmandu, Nepal. I'm an emergency physician, so I'm really delighted to be here among you all. So let me start my presentation. I'll be giving you a short, briefly, I'll take you from the evolution of the emergency medicine in Nepal to like moving forward. So to begin with, so I wonder how many of you recognize this mountain? Anybody? So exactly, this is Mount Everest. So this is my country, Nepal, with beautiful mountains, and this is the tallest mountain in the world. This is Mount Everest. So Nepal, as you might know, it is a small landlocked country with 30 million population. It is in Southeast Asia, neighbored by India and China. So just briefly about the constitution of Nepal. So as per our constitution, our country's constitution, it states that every citizen shall have the right to free basic health services. And it's like no one shall be deprived of emergency health services. So even the Constitution of Nepal has focused on emergency care. So that way we're quite lucky. Just a few numbers about the health services delivery in Nepal. As per the latest annual health report, we have around 200 public hospitals, followed by a few primary healthcare centers and health posts as well. But a larger number of private facilities, like 2,000 plus private facilities. So talking about the tertiary care centers, these pictures show the place where I work. This is Institute of Medicine, Tribhuvan University Teaching Hospital, where I work. So this is a multi-speciality tertiary care hospital. If it is the biggest referral center in Nepal. We have pre-hospital services, we have ambulance services, even helicopter rescue services these days. We cater around 200 patients per day in the ED itself. It's a 1,000-bedded hospital. So I work in this hospital. So if I have to show you another picture, this again is the picture that we find every day in our emergency. The first picture, as you can see, it is the picture that you can see in the yellow area of my hospital where I work. So it is, every day it is crowded, it has patients flowing from everywhere, patients gets referred from everywhere, so we don't even have like beds, enough beds, so most of the time it's like 1 bed, 2 patients. So this is the scenario of our emergency right now. And the second picture, it is a picture of the red area, a regular day at the red area, I should say. It is mostly crowded, almost always crowded, I should say. So I just wanted to show you the real scenario of our hospital. This is a tertiary care center. So if I have to take you from the tertiary care centers to a rural health center where I used to work a couple of years ago, there are primary healthcare centers, there are health posts as well, and we were the ones who would do everything in that rural center, from taking care of the emergency, to seeing patients in the OPD, the outpatient departments, and even some emergency surgeries like an emergency C-section. You can see myself doing an emergency C-section in the picture. So the rural health center is entirely different from the tertiary care centers that we have over here. So this is probably the harsh reality that is there, still evident in our country. This is a small health post, quite isolated, with a tin roof, less infrastructure, less manpower. So this probably is the harsh reality that is still evident in the rural areas now. The scenario is getting better, but then we still have these health posts and primary healthcare centers in our country. So if we look at the ground situation in our country, we still have to go a long way in terms of infrastructure, in terms of human resources. The equipments are still needs to be added, I should say, drugs, and we don't have proper protocols, and we are still trying to catch up with the academics, trainings, and research. So just a bit about the evolution of emergency medicine in Nepal. So this is at an infant stage yet. It's a new specialty in Nepal. The Doctorate of Emergency Medicine, we call it DM in Emergency Medicine program. It was started in 2011 in our hospital, the place where I work. That's Maharajganj Medical College, Institute of Medicine, Tribhuvan University, Teaching Hospital. And this was in collaboration with the Australasian College of Emergency Medicine. So this is a PhD degree, equivalent degree. We do it after our post-graduation, and it's a 3-year long degree. So till date, we have had 8 graduates. About women in emergency medicine in Nepal, I have to say that there are only a handful of emergency physicians in the country. Emergency care, it is delivered by general practitioners who are also trained in emergency medicine for a few months. And if I have to give you the numbers, the trained female emergency physicians who have done at least a fellowship or a doctorate, 39% of them are there. So coming on to the academics, I would like to tell you that I take great pride in telling you that I was one of the first female emergency physicians in the history of Nepal to be trained in emergency medicine in Nepal. So I consider myself lucky for that. And my role, if I have to tell you my role, I now supervise doctorate students, postgraduate students, interns, junior interns, even foreign medical students are there, paramedics, and even the nursing staff. But there are challenges, like everywhere, there are challenges in our academics as well. So we have been trying to develop a curriculum, a postgrad curriculum, the first ever curriculum of emergency medicine in Nepal. It is very complex. We have realized that it's very complex. Starting a specialty program, especially in emergency medicine, is quite tough in our country. But then we have been lucky. I have been involved as one of the leaders in developing the curriculum of emergency medicine. So we'll be taking residents from this year onwards in emergency medicine. So talking about other good things, positive things that we have in Nepal, we have developed a standard treatment protocol. I have been lucky to have been involved as the team leader in association with the Ministry of Health and Population in Nepal, and also with the country office WHO Nepal. A standard treatment protocol has been developed. It has been 2 years now. A standard, concise, reader-friendly, in a very understandable language, a book that was developed in association with the Ministry of Health and Population. So this focuses on ensuring the highest quality of emergency care all over the country, especially in emergency care. So we have been successful to a large extent after this book came out. So after this, what we have been focusing is that we have also developed a facilitator's guide so that we implement this and we roll out to all the provinces in the country. So this has been also successful to a large extent. So you can see a few pictures. We are giving lectures. We are trying to build facilitators. So we have had hundreds of facilitators till date. So I've also been involved in research. That is one field that I love to explore. So I've been lucky that way. There's an association called OCRU, that's Oxford University Clinical Research Unit, based in UK, but we have a branch in Nepal as well. So I have been supervising an RCT, that's a randomized controlled trial. It's called the ACT South Asia Study. So we deal with acute febrile illnesses, especially enteric fever. So it is an azithromycin cefixime trial, an interesting trial where I lead as the supervisor. I am the person whom they approach when they have any kind of a clinical dilemma. So that is quite interesting. And we are also a part of the recovery trial in COVID. And apart from that, in my own college, I have started a prospective study, a simple study, just to see the patterns of poisoning, because the number of poisoning cases that come in our emergency is overwhelming. So apart from that, a lot of training programs are going on, from primary trauma care to basic life support, to advanced cardiac life support, to basic medical emergency technicians, even the Civil Aviation Authority of Nepal. So we have been giving lectures and we've been training a lot of people that way, at least the first aid or the basic life support. So talking a bit about women leadership in Nepal, it is growing, I should say, that it's steadily growing in Nepal. We have had the first ever president, the female president in the country. And in our institution, that's Institute of Medicine, we have the first ever woman dean. It's a proud feeling for everybody. And even in Oxford University Clinical Research Unit of Nepal, there's a first woman director now. But then having said that, we all have still like sensitive issues regarding gender, and it's still prevalent in Nepal, to some extent, I should say. So let's talk about the challenges then that are still there. As an emergency physician, the challenges that I have faced or many of the female emergency physicians have faced. So gender discrimination, it's there at the workplaces regarding opportunities actually for us. Maybe in the leadership positions, we're still a little backwards, I should say. Maybe equal representation is still something which we are trying to focus on. We have less women speakers in conferences. We still have less women speakers in the conferences. And talking about the pay scale, I've been lucky in this matter because I did not have an issue of, being paid less as per my position. So that way, it's not an issue, I guess, for me at least. And something interesting that I would always be told by the society or my male counterparts, it's emergency medicine. When I took up emergency medicine, I was always told that it's a really tough thing to be taken. It's very demanding physically as well. So it's a male thing, they say, and it's not a woman's cup of tea. So I've been hearing this every now and then. And something which is quite strange, maybe it's kind of a trend in Nepal, we are most of the time addressed as the nurse. With due respect to all the nursing staff, we cannot do without our nursing staff and the nursing team. But then we as doctors, like female emergency physicians, when we are working in the emergency, running here and there from the red area to the yellow area, we are always addressed as the nurse. Because even if they know that we are doctors, we're treating the patient, the society, I think it's still hesitant to accept this change that, okay, this woman is a doctor leading the emergency. So that is something which you will still find in our emergencies. Some positive things again, apart from the challenges that we have. So we have developed a society, it is known as EDSEP. It's called Nepalese Society of Emergency Physicians. And I am an executive board member. I'm actually the treasurer of this society. So this society is a voting member of IFEM as well. And I also represent the GSI-SIG, that is the Gender Specific Issues Special Interest Group of IFEM from Nepalese Society of Emergency Physicians. So that is something good that we have in our country now. And regarding SAEM and AWAEM, I'm very grateful to all of you. It's an inspiration for women like me and all the other aspiring female emergency physicians from the low middle income countries especially. I feel that it's a huge encouragement for everyone like me and back home. And maybe by connecting with all of you, all the women emergency physicians across the globe, learning about leadership and also maybe creating opportunities for aspiring female physicians that would like to take up emergency medicine in the future. So that is always there. So coming on to my last slide, I should say. The way forward, I plan to conduct workshops, conferences, wherever possible in my country. Maybe also address the barriers if I can, bridging the gap, maybe by acquiring skills, by developing a bit of research from my experience here, and building also networking, knowledge, and ultimately to strengthen the quality of emergency care in our country. So that is what I would like to focus on. So I'd like to end with a simple picture here. So this was taken by myself when I was doing a workshop in a place called Dhulikhel, that is 1 hour drive from Kathmandu. So this is a beautiful sunrise, but then I would like to compare this picture with the emergency medicine situation in our country. It's still at an infant stage. There are still a few clouds here and there, but then don't you think that the sunrise is beautiful? So I think it's a promising beginning for all of us, especially in a country like mine, where emergency medicine is just trying to grow. So I am quite optimistic that it is a promising beginning for everyone, especially in emergency medicine. So thank you so much. This is our national flower, rhododendron, so I would like to just virtually offer you these flowers. So thank you so much.
Thank you so much, Dr. Olita. That was really inspiring, and I learned a lot. Does anyone have any questions for her? We do have to use the mics.
Hi, Sharon Chikichan from Yale University School of Medicine. Thanks for your presentation. You mentioned that you're just starting the residency program, so I was wondering if you could tell us about your journey, how you decided to do emergency medicine, and how you received your training. Were you self-trained? Did you travel? I'd be really interested to hear.
Yeah. So it's like I was always interested in emergency medicine. I was somehow or the other fascinated by what happens in the emergency. Like a person goes to the emergency with pain, and then the doctor over there, like, he will relieve the pain, like something that person will be taken care of. So I was always inspired by that scenario. Maybe I had my grandparents who I would like follow my grandparents, because he is no more now. But then my grandfather, he was a patient of COPD, and we had to take him, we had to rush him to the emergency every now and then. So maybe I was, as a kid also, I was in the emergency for, like, I had seen this whole scenario, like the busy emergency, and then how my grandfather's like shortness of breath would get instantly relieved. So I was quite fascinated maybe from that, maybe. So when I finished my undergrad, I did not know like what to pursue as a doctor for my postgrad and my doctorate. But then luckily there was a path that I could follow. A few of my seniors were there, and then I slowly pursued this as my career, I should say. And I am trained in Nepal only. I've not been out of Nepal. I've been trained in the same institution that I'm working as a faculty now. So everything, whatever, from my undergrad to my postgrad to my doctorate, I'm there, I should say. And does that answer your question? Or? Yeah.
So it's been more of an apprenticeship than an organized residency training. And then the subject matter you studied for your dissertation was more in emergency care?
Exactly.
Got it.
Exactly.
Thank you.
Any other questions for Dr. Olita?
Just a comment. I just
Yes.
want to commend you as a pioneer. It's difficult. The road
Yeah.
is hard.
Sure.
And so we just want to acknowledge your efforts and you being a champion for many. Representation is important. And
Exactly.
to envision the future for many young women, young girls in Nepal, the future in emergency medicine as a possibility. So you are an inspiration. The work that you're doing in emergency medicine to develop it, and as a woman for gender, that's incredible. So I just want to commend you for your courage,
Thank you.
your
Thank you so much.
fortitude, and to being told that it wasn't a good thing for you and a good fit, and that you did it anyway because you followed your dreams. So you are an inspiration to many of us. So thank you so much.
Thank you so much. Thank you so much.
Okay, next we'll hear from Dr. Salote Behr. She's from Fiji. I'll tell you a little bit about her. So she's an emergency physician and acting chief medical officer, head of department in the emergency department at Labasa Divisional Hospital in Fiji. She's one of the first emergency trained physicians practicing in Fiji and is currently leading a young cohort of enthusiastic doctors. She's worked in multiple resource-limited healthcare settings in Fiji with special interests in global emergency care. She's recently achieved a certificate with high distinction in capacity building in global emergency care, in addition to a certificate with distinction in clinical leadership and management. Her interests are in critical care, pediatric emergency medicine, pre-hospital care, academic research, and education. And thank you for your inspiring work in Fiji, and we are excited to hear more about it.
Thank you. Thank you, Dr. Mindi. Bula, and hello, everyone. I'm Dr. Salote Behr. I'm based in Lambasa Hospital out in Fiji. I'd like to take this time to acknowledge the Academy for Women in Academic Emergency Medicine, as well as the GEMA committee, for allowing me this grand opportunity and honor to be a part of this presentation. I'll be presenting briefly on the development of emergency medicine in Fiji. So you'd be asking, where is Fiji? And what is so different about Fiji? Well, I don't want to brag about it. It's the most beautiful tropical paradise. So if you want to do emergency medicine, that's the best place to go to. Briefly, Fiji is an island nation located in the southwestern Pacific, in the tropics of the southern hemisphere. It's about 3,000 kilometers away from Australia, midway between Vanuatu and Tonga. Approximately 330 scattered islands, and only a third of those are occupied. We are famous for our rugby, and not only that, we have a diverse multicultural history as well. We have two major islands you can see in the far right corner. So the first island, the biggest one, is Viti Levu, which has a majority of Fiji's population, which is about 915,000 people. That's overall the Fiji population. I'm actually based at the second largest island, which is Vanua Levu, up on the right-hand corner. Now, for emergency medicine, it's a relatively new specialty since its inception about 10 years ago, where we had our first diploma candidates that joined emergency medicine. And then later in 2014, we had our first group of masters in emergency medicine starting the specialist training. So there was only 6 of them, led by Dr. Ann Creighton, one of the greatest EM physicians we are so blessed to be a part of. With these graduates, our first EM pioneers graduated in 2016 and then finally became recognized specialists in 2019. So basically our local pathway for all specialists, they need to go through a 2-year under supervision, probation after graduating masters, which is similar to a residency program here. And after that, once they've achieved their peer review, then they become recognized as specialists. In Fiji, we have so far 20 specialists. From those 6 in 2019, 15 of them are based in Fiji, and 3 are currently abroad in New Zealand and Australia, where they're attached. 1 is in Solomon Islands, and 1 in Tuvalu. So far, from that, 9 were females and 11 males. We have a steady stream of postgrad diploma trainees, with about 6 to 8 of them per year. And we've had doctors from all these 9 countries within the Pacific region that have gone through the program. So not only from Fiji, we have other countries like the Solomons, Samoa, Timor-Leste, Tuvalu, Tonga, and so forth. One of the main achievements from this EM program, we were able to develop our quality standards document based off the ASAEM quality standards document as well. And this was developed in 2022 during our World EM Day, and we hope to launch it later this year. Also, another achievement we've had is having a full EM faculty, local faculty, based at the Fiji National University, made up of our 3 of the EM pioneers. Yes, so on the right-hand corner. The other thing is decentralization of EM services in Fiji. So as you can see, Viti Levu is the largest island in Fiji, where our main tertiary hospital is, in Suva, which is the capital of Fiji, where that main hospital is, a Colonial War Memorial Hospital, where I went through the program. And from there, we managed to, from the 15 specialists, we went out into the rest of Fiji, and we have other hospitals based in Lautoka, Behr, which is the western part of Fiji, and then right to Lambasa, which is the northern part of Fiji, where I'm at the moment. In addition to that, we've also we've built partnerships and networking with various local and international bodies, including the Australasian College of Emergency Medicine, where a few of us are internationally affiliated with, and through that we're able to have access to the educational resources, the mentorship program, as well as documents and the policy documents and guidelines. We've also tried building a relationship with the IFEM community through their special interest groups, which I'm a part of, the PEMCEG, which is Pediatric and Emergency. And also through this, we were able to attend the ISEM conference last year, which we participated in as well. We've also partnered closely with our local community organizations like the Volunteer First Responders, International Women's Association, likewise regional bodies like the South Pacific Community and other private corporate companies. In terms of research, our postgraduate master's program, our senior EM trainees, they're required to go through a research they have to present on in their final year. And a few of the topics that we've had so far as such, where someone did a study on patient satisfaction, burnout, accuracy of triage, pre-hospital demand, and door-to-needle time for STEMI. We still have the need to encourage our students and doctors back home on how important it is to do research and publish it. 2 of these researches were published, the first so far, a few of them, and 2 that I'd like to highlight here, one of which was published in the Emergency Medicine Australasian Journal in 2019. This was a study done on improving emergency department trauma care in Fiji. This was done by Dr. Lavinesh, along with Dr. Ann Creighton and Dr. Georgina. Also last year, when we had the 21st ISEM conference, they displayed this study that was on experiences of leadership in emergency medicine in the Pacific. In terms of our education and training, this has been made possible by most and all of these great EM physicians, most of them made up of fellows from the ASEM College. The pathway to doing an EMED program in Fiji, initially when completing the 6 years program of medical school, then you do a year-long of internship, followed by up to 1 to 2 years community or rural health facility attachment. And if you have any interest in emergency medicine, you'd have to send in an expression of interest, and then you have to work for at least another year in the emergency department before you're considered into the program. It is a demanding program as well because we have limited lecturers and the need to fund it effectively to run the program. Because of the EM program, we are able to train our local graduates, our own EM graduates, to do further trainings within the country, like ACLS, primary trauma care. We've also had the opportunity to, because of the networking, we had a team from the US that came last year to do a POCUS training with us. In addition to that, we've also worked in close collaboration with the NCCTRC, which is the National Critical Care Trauma Center in Australia. Through their disaster response program, we're able to run the MIMS training, which is Major Incident Medical Management Support Training. And this has allowed us to become trained and become local trainers as per the ALSG guidance. Another course that we've managed to do, this one is the ELS course for doctors and the Siren course for nurses, which was a culmination of liaison work and planning since they were commenced in 2013. Basically, they were commenced in 2013 to complement the EM training that we started off with, and also having a parallel run trainings with the nurses because we saw the need to bridge the gap in terms of the knowledge and skills in emergency care. We've also involved ourselves with the volunteer first responders, so that's part of the pre-hospital care, where these are all passionate volunteers, all full-time, all with full-time professions. We work and train and also help the hospital emergency departments as well as the Fiji Police Medical and Response Units, the Republic of Fiji Navy, basically just to enhance and support emergency care services around Fiji. We also have an EM attachment in the medical internship program. For the internship EM rotation, it's about 10 weeks long, where they are closely supervised. We assess them on their clinical skills and knowledge, as well as professionalism, and so forth through the teachings within the department. EM Fiji local and abroad. So there's a yearly conference that's usually been done, the Developing EM, and we were lucky to have it conducted in Fiji in 2018, so we were part of that. And then in 2019, we were part of the Critical Care Conference, the SMAC conference in Sydney, and then last year at the ISAM. So we were represented there as well. None of this would have been possible. I wouldn't be here standing in front of you if it wasn't for this inspiring individual, Dr. Ann Creighton. We call her the mother of EM in Fiji. She started the MEd program in Fiji. She's a former associate professor of the Fiji National University with background fellowship in ASAEM and aeromedical retrieval with special interest in global emergency care and medical education. So I'm grateful for her. Now, the future. What's the future for EM in Fiji? More capacity building and partnership, just increasing our visibility globally. We're trying to form our own society. We have yet to come up with that. And in addition to that, the Pacific Island Society of Emergency Care, we've briefly formed it, but through the IFEM support, we hope to continue more in the future, as well as expansion of the EM program to include more regional candidates once we have more faculty members to join the program. Also, research and publications, we'd like to have more of that in the future, knowing that some of the studies that we've done are mostly the first for the Pacific, so we are quite, I think we just need more support in that aspect. And also having EM-trained doctors in every health facility in the Pacific, in Fiji and the Pacific. Vinakavalevu, and thank you very much. So I don't want to brag again, but Fiji was 2-time gold medalist in the Olympics, and we're famous for rugby. Thank you. If you want to contact me, my email and my Twitter is there. Thank you.
Thank you again. That was really wonderful and interesting and inspiring. Any questions for Dr. Salote? There's a theme building here.
So I always have questions. I'd just love to hear about the pre-hospital system and what state it's in and what some of the challenges are, if it exists. And have you been working on protocols?
So the pre-hospital system, we don't really have a paramedic provided. We just recently began a program, like a certificate program, where we have interested applicants that can apply into the Fiji National University. So it's accredited through the Fiji National University, where they can attain a certificate. And the faculty involves most of our EM physicians, the ones that are in the FNU, and they go through, I think it's a year-long, probably half a year course, We've had a few participants in that course as well. And most of them come from from the police response unit, and in terms of pre-hospital care, we've just worked closely with the volunteer first responders, which is a community voluntary organization. So in terms of retrieval from the health centers and all, it's basically us. We're just the ones doing the retrievals, and we don't have an actual system in place at the moment.
Somebody else?
Hello, hi. My name is Liga from Kaiser Permanente. For both speaker, is there any curriculum for emergency medicine in your country? And if there's any, will you model it from IFEM or SAEM? Because I know you guys have different medical students curriculum, right? Based on Commonwealth, I think. I don't know. That's what I'm thinking.
Sorry, can you repeat the question?
My question is there any EM curriculum for medical student?
Oh, for medical
And if
students.
there's any, will you model it from IFEM or SAEM?
That's an interesting question. So at the moment, for our undergraduates, the EM curriculum is, for them, the attachment for us is just a week long. We feel it needs to be a bit longer because they need more exposure in terms of emergency care. But I think usually we go through the ASAM pathway if we want to adapt something in our country, because we base most of our EM curriculum, the postgraduate program is adapted from the ASAM curriculum itself. So if we were to do something for medical students, we'd have to go through them first before going internationally.
So what I
IFM.
hear you saying, in Fiji, in medical school, there's not an EM concentration at this time,
No.
or really opportunities for special.
So it's still part of the specials rotation at the moment.
okay.
So specials rotation is like eye radiology. So EM is still part of the specials rotation, which is just 1 week long,
Okay.
which is not enough.
What about in Nepal, Dr. Olita? Is there something different there for medical school?
For the undergrads, we have 2 weeks of rotation, but then we do have like postgrads. The general practitioners are there. They're posted for almost 6 months in the emergency, in their 3-year-long residency. And we do have doctorate residents as well who are there for 24 months or more in their 3-year-long residency, which I also went through. So yeah, so we do have residents and the interns and medical officers as well.
Hi, I just want to say that I'm really happy to see that we share the same mother in emergency medicine, Dr. Creedon, although I'm from the Philippines. And congratulations on your program. I've met Lavinesh in EMS Asia. My question, though, is that you said you had 330 islands in Fiji. The Philippines is 1,107. How do you manage if you have in retrieval medicine? How do you manage emergencies from the other islands to get to your island or other centers?
Thank you for that question. So we make use of our primary healthcare systems. So we usually get calls from the primary healthcare setting if they have a case that needs to be retrieved. And we have to go through a system within our hospital, in the tertiary hospital, where we need to go through the logistics and all. And then we identify if we are not too short on the floor, we need to get someone who's more skilled to actually go out and retrieve them. So it's only accessible through air. We have boats as well, but it takes longer time. So depending on the severity of the case, we usually have to get emergency evacuation plan in place. Ideally, during the day. If it's after hours, they usually have to wait for the next day to come across to us, unfortunately.
So what I hear you saying, from your hospital, at times you will go by air to retrieve sick patients from other islands, and you will send someone trained, that is trained from your facility, ideally.
Ideally, but in my setting, because I'm the only consultant, emergency consultant in my department, either we get someone from the ICU if the patient is critically unwell, needing airway intervention, or the other possibility is just to get a senior person from the floor, which is a risk in itself. In terms of getting cases from the health centers to us, so most of them are geographically like really far apart. Takes about 2 hours by ambulance at least, or the furthest is like 4 hours, so 2 hours there and 2 hours back to us. Nurses end up retrieving those cases.
So it sounds like your hospital does have ambulances that can go out and get patients.
We do, but limited, and most of the time it's not functioning, and we have to end up sending something else, another form of transport just to get cases.
Anyone else?
Hi, Valerie Dobias. Good to see you again
Thank you.
from the AWAEM conference yesterday. Just curious, you talked about the mother of emergency medicine, women in emergency medicine in Fiji. So the original classes, or what's the gender dynamics? If you have any comments about that, would appreciate your thoughts.
Yes, so I mentioned there's so far 9 female specialists out of the program. 11, sorry, did I say 9? Yeah.
9 and 11 is what you had on your
11
slide. Yeah,
males.
9 women, 11
Yeah,
males, right?
11 males. When I joined the program, there was just 4 of us, and we were all females. And yeah, we went through the program successfully, and we all passed. And with Dr. Ann Creighton, she has been a really great, inspiring person to work with, and she helped us a lot, yeah, through this.
Hi, my name is Naz Kareem. I'm the president of GEMA. I just wanted to take a minute to, thank both of you so much for coming from such a distance. I mean, I think it's maybe 10 or 11 p.m. in your regions, and like 2 or 3 in the morning in Fiji. So thank you so much. You guys must be tired. But your work is so inspiring, and I think one of the goals of having you present here is so that we can learn from you, and I think we have definitely accomplished that. Thank you so much for your hard work. We are truly inspired and very grateful for you coming to this conference.
Thank you.
Thank you so much.
Thank you so much.
I'd love to get a picture of the president of AWAEM and president of GEMA with these ladies after, but in closing, thank you all for coming. Please come say hi to these women, meet them. Think of ways they could maybe lecture at your institutions virtually, in person. Think about ways you could collaborate on research. Think about ways you could visit their countries to increase capacity there. So please collaborate, chat, meet each other. Thank you very much.